Hello, everyone. This is Dr. Kripal, an MD Pharmacology from CMC Ludhiana. And as in one of my previous sessions, I talked about the new CBME competency in pharmacology, that is PH 1.15, which says describe the mechanism of action, types, doses, adverse effects, indications, and contraindications of skeletal muscle relaxants. In the first part, we talked about the mechanism of action. Now we'll continue beyond that to various pharmacological actions and uses of these skeletal muscle relaxants. So just before we commence into these, we go into deeper into the various pharmacological actions. I would like to give you a brief recap. And prior to that, just a brief information that if you have any questions or queries pertaining related to regarding skeletal muscle relaxant, you can write down on the chat box and I'll get back to you. So let's start with this, where we had covered the skeletal muscle relaxants. We had talked about skeletal muscle relaxants being divided into two broad categories of peripherally acting skeletal muscle relaxants and centrally acting skeletal muscle relaxants. The peripherally acting skeletal muscle relaxants tend to act on the neuromuscular junction or the muscle fiber, whereas the centrally acting act on the cerebrospinal axis, which are mainly used for painful spasms or spastic conditions, whereas those acting on the neuromuscular junction are as an adjuvant to general anesthesia. Now, the peripherally acting are further subdivided into drugs acting on the NM type of receptor and drugs acting on the muscle fiber. So drugs acting on the neuromuscular receptor are further subdivided into two broad categories. One is the non-depolarizing one, non-depolarizing competitive blocker or depolarizing non-competitive blocker. The non-depolarizing competitive blocker is further subdivided into long-acting, intermediate-acting, and short-acting, whereas depolarizing has two broad drugs in its category, that phenylcoline and dexamethasone. Then we talk about directly acting agents. We had dantrolene sodium and quinine. Talking about the action, they could either block the action of acetylcholine, that is what I told you in the previous session, or they could mimic the action of acetylcholine, having some maximal activities over the and the inhibition. The activity is prevented by the enzymes are not able to overcome catalyze this particular drug, so the muscles become overtired and the muscle is not able to move. Now, this was a table that we talked about, and then this is the site of action that I had talked about. Talking about the mechanism of action, we talked first about pachycurare, which is the competitive blockers as devised by Bovet. And as I told you that it had two quaternary nitrogen atoms which had high affinity for acetylcholine binding site. The molecule binds to this and reduces the opening of the channels, so end plate potential is not generated, and this does not lead to mean action potential generation. This was surmountable by anticholinesterase. Now, when we talk about this, the depolarizing blocker or the non-competitive blocker, I told you they have affinity and some maximal intrinsic activity. They were termed leptocurare by Bovet, and these drugs, they tend to depolarize muscle and plates. So first there is the opening of sodium channels, which leads to fasciculation and twitching. And now as these drugs are not catabolized or not metabolized by the enzymes present there, so they do not tend to dissociate from the muscle and plate, so this leads to flaccid paralysis. And so there are two types of block. One is phase 1, the other one is phase 2. Phase 1 is due to the opening of the channels, and phase 2 is due to persistent presence of this particular drug on that particular channel. And I had described about this particular drug. Now, when we talk about the actions of this particular drug, now, when you talk about the non-depolarizing blocker or competitive blocker, the first, obviously, we talk about the pharmacological action. The first organ that we need to talk about is the skeletal muscles. If you give an IV injection of competitive blocker, it causes rapid muscular weakness, which is followed by flaccid paralysis, starting from the smaller muscles, that is muscles of the hand, and finally diaphragm is involved. The peak effect of these particular drugs would depend upon the drug, the dose, the anesthetic used, and the status of the patient. Whereas when you talk about depolarization blockers such as succinylcholine or dexamethasone, they cause fasciculation first, which is followed by flaccid paralysis. So whenever we are talking about this, we need to monitor whether muscle relaxation has occurred or not. And this is done by recording the contractile response of thumbs. So we go look for few parameters. These are the train of four, the train of four ratio, the double burst, the tetanic stimulation, and the post-tetanic count. So what is this train of four protocol? Train of four protocol is we tend to give some maximal stimuli at 2 hertz to the muscle, and train of four ratio is where we divide the strength of fourth contraction by the first one. Double burst is two contractions are given. Technique stimulation we have already been talking about, and the post technique count that is there. So let's talk about how this particular thing occurs. Now, when we talk about train of four, so the train of four is giving some maximal stimulus. You see, when no drug is there, the response is equivalent. As you tend to give competitive blockers, it tends to fade off, and the train of four ratio is 0.4. Whereas when we talk about phase one, you have a diminished the drug is bulky, so the response is diminished, and the TOF ratio is 1. Whereas in the phase two, that mimics the non-depolarizing or competitive blocker, it has a ratio of 0.4. Double burst is you are giving two stimuli. In competitive blocker, it tends to fade off, whereas there's no fading in the phase one, and again a fading off in the phase two block. The post-static stimulation and the post-static count is more than 6 without the drug. With the drug, it is equal to 3, whereas post-static count is absent out here when we are giving the phase one of depolarizing blockers. Talking about the other actions of this particular drug, now these drugs, they are competitive blockers and they produce some degree of ganglionic block also, and this block occurs leading to ganglionic stimulation. Some drugs, due to the bulky nature, lead to release of histamine. D-tuberculin is known to cause release of histamine. Now, this release of histamine could lead to hypotension, flushing, and bronchoconstriction. In the CVS, there is fall in the BP. Now, this fall in the BP could be due to variable reasons. It could be due to ganglionic blockade. It could be due to histamine release. It could be due to reduced venous return. Although there are few drugs such as pancuronium and vicodinum which cause tachycardia, whereas succinylcholine has bradycardia followed by tachycardia. Also, succinylcholine causes a rise in blood pressure, and its prolonged use could lead to soreness and arrhythmia. In the GIT, this particular drugs could enhance the post-operative paralytic ileus, whereas when we talk about their action on the CNS, they generally do not cross the blood-brain barrier. But obviously, if there's a direct application, which is rare, it could lead to a CNS stimulant effect. Talking about the pharmacokinetics, all these drugs are polar compounds. That means that they are water soluble. So if they are water soluble, they are restricted to the extravascular compartment. They are only to be given by the parenteral route. The duration of action of these blockers would depend upon the elimination half-life. These are mainly excreted by the kidney, whereas when we talk about succinylcholine, which is the rapidly acting drug and most frequently used, it is rapidly hydrolyzed by the plasma pseudocholinesterases in the plasma. Talking about these individual compounds, some of them are required. Succinylcholine is one of the most commonly used compounds. And why it is used? Because it has a rapid onset of action. It has a complete and predictable recovery. Also, it has a spontaneous recovery. Now, this particular drug, it causes relaxed jaws. The vocal cords are apart. There is no hindrance to the diaphragmatic movement. But it causes soreness, as I told you earlier. It can lead to a change in blood pressure and heart rate. It could lead to arrhythmia. It could lead to histamine and even potassium efflux. So that we have to keep in mind. Pancuronium, another drug that is an intermediate acting, is more potent than D-tuberculare, has good cardiovascular stability, not related with histamine release, but its rapid IV injection could lead to BP and tachycardia, and reversal is required out here. When we talk about succinylcholine, let me remind you that this particular drug is metabolized by plasma pseudocholinesterases, where this particular drug requires anticholinesterase drugs or cholinesterase inhibitors such as neostigmine. Few more drugs such as vecuronium has a short duration of action. It has rapid distribution and recovery, spontaneous recovery. Atracurium and cisatracurium are known for their Hoffman elimination. They undergo metabolism degradation spontaneously in the body, and they could be used in patients who are having kidney failure. Mivacurium, for all practical purposes, is one of the most shortest acting or the shortest acting competitive blocker that could be given. Talking about its interaction, which is obviously one of the things that is there, it should not be given with thiopentone sodium in the same vial as they can react chemically. It is given with general anesthetics. When given, it causes potentiates the competitive blocker. There are all chances of having malignant hyperthermia, and halothane can attenuate this with succinylcholine. Anticholineesterases tend to reverse the action of competitive blockers. Aminoglycosides, such as antimicrobial agents, such as aminoglycosides, are also cause neuromuscular blockade. So they could potentiate the action of skeletal muscle relaxants. The calcium channel blockers could also potentiate the action of skeletal muscle relaxants, whereas diuretics could enhance the block. Regarding the toxicity or adverse effects, these drugs could lead to respiratory paralysis and prolonged apnea because diaphragm is paralyzed. It could lead to flushing due to release of histamine, which could cause fall in BP and cardiovascular collapse. Cardiac arrhythmia is always there with succinylcholine. Release of histamine could lead to perspiration of asthma, and succinylcholine is associated with post-operative EDS. Where are these drugs used? These drugs are used as an adjuvant to general anesthetics, and the action obviously would depend upon the duration of block, the cardiovascular effect, and other diseases. Succinylcholine is most commonly used for endotracheal intubation, laryngoscopy, bronchoscopy, reduction of fracture and dislocation. It could also be used for convulsions and trauma from ECT, and as well as tetanus and status epilepticus. Talking about the other group that act directly on the muscle fiber, we have two broad category of drugs. One is the dantrolene, the other one is quinine. The dantrolene is a drug that uncouples the contraction for depolarization of muscle membrane. How it does that? It decreases the calcium release from the sarcoplasmic reticulum. When used orally, it could reduce spasticity in upper motor neuron disorder. It could be used in hemiplegia, paraplegia. It could also be used in multiple sclerosis. Now, this particular drug is a drug of choice for malignant hyperthermia. Certain adverse effects are associated with dantrolene, which include muscle weakness, sedation, malaise, lightheadedness, and diarrhea. Quinine tends to increase the refractory period and decrease excitability, but it has its own set of toxicity and adverse effects. So this particular drug is mainly used for nocturnal leg cramps. Talking about the centrally acting muscle relaxants that act on the cerebrospinal axis, and these drugs are used for painful muscle spasm or spastic conditions. We have mefenacin group, which include mefenacin, carisoprodol, chlorzoxazone, chlormazone, benzodiazepines such as diazepam, GABA derivatives such as baclofen, and central alpha-2 agonists such as tizanidine. So when you talk about mefenacin group, this is a muscle relaxant, has a sedative action, is weakly analgesic, antipyretic, and it also has an anticholinergic effect. All these drugs differ in their oral toleration and duration of action. Diazepam enhances the GABA transmission. Baclofen is an analog of GABA aminobutyric acid, whereas tizanidine is a clonidine congener. Now, where do we use these drugs? These drugs are generally used for acute muscle spasm, torticollis, lumbago, anxiety and tension, spastic neurological disorders, tetanus, ECT, and various orthopedic manipulations, which include setting of fractures and dislocations. So this is all regarding the skeletal muscle relaxants, and I hope that I've been able to clear some doubt and give some clarity on this particular topic. If there are any questions or queries, you can write down to me on my chat box, and I'll definitely get back to you. Thank you so much for your patient hearing, and have a nice day. Thank you so much.